Hey guys, this is Dr. Charity Stanley, and this is Introduction to EKG. So, EKG is something that many nurses really don't get, um, and they think it's a bunch of just squiggles on a page that doesn't make much sense to them. But it's very important that you know what these different squiggles mean because they actually have important stuff. So I found this meme, EKG Made Easy, the humpy bit. The humpy bit is the PR interval. It's the P wave where the complex is started at the SA node, then goes through the QRS or the jiggly bit. And then the lumpy bit is where it's all getting ready to happen again. That's the T wave. So, things to look out for, squiggly stuff you have no idea about, but the patient looks really bad. And yes, that's definitely something to watch out for. So, when we're talking about EKGs and we're talking about leads, that's one of the most confusing parts. It's really super simple though. So, yeah, I've got different pictures of a car up on the screen. And the reason I have it up there is because this is just like our cardiac leads. So if I am walking up to my car and I see the driver's door, then that is my viewpoint. The passenger's door is still there. It's on the opposite side. I just can't see it from my vantage point. So if I have a cardiac lead that's looking at the top part of the heart, it can't see the bottom part. We know it's still there, just like we know that passenger door is still there, but you just can't see it from that vantage point. So if you look at the lead that's looking at the bottom part of the heart, then you'll be able to see that part, but it doesn't give you information on what's going on in the top um, part of the heart. Just like looking at the passenger door, we won't see that big scratch on the driver's door. Okay, so when we're looking at different leads, we're looking at different parts of the heart individually. And like just the same as if we looked at a picture of different parts of the car. So it gives us a picture of different ways that we can perceive and look at the heart. And this is a picture of our heart in different viewpoints. So our first viewpoint is looking at the very tip top of the heart where the aorta comes out. And next, we're looking at the position that it would be in the body. And then third photo, we're looking at closer to the bottom part of the heart. And then we're rotating that heart through different images. Now, we are looking at, with EKGs, electrical pictures. This is a picture of the electricity as it's running through the heart. Our lead placement. We have 10 leads that gives us 12 pictures of the heart. And how do we do that? We're going to talk about that here in just a minute. The precordial leads are also known as the chest leads. These are our V1 through V6. We'll get more in depth with that as well. So that's 6 leads is our precordial leads. Then we have 4 leads that are called limb leads. This is our right arm lead, our left arm lead, our RL, which is right lower or right leg, however you want to refer to it. Our RL is the ground. All it does is make sure that the rest of the system works. And then finally, our last lead is LL, or left lower. And Einthoven's triangle is how we can actually have 6 leads come out of 3 individual leads. And we're going to go into more depth on that as well. The RL is the ground. Now, if telemetry keeps calling you and saying, hey, I don't see your patient, you've gone in there and looked and it looks like everything's hooked up, everything can be hooked up but that RL lead. And if that lead is not hooked up, the system is not grounded and telemetry can't see anything. So when your patient, they're saying they're not hooked up, and that really needs to be one of your first troubleshooting areas. Einthoven's triangle is composed of the limb leads. So now we're looking specifically at the RA, the right arm, the LA, the left arm, and the LL, the left lower or left leg. Lead 1 is the difference between the right arm and the left arm. So if you think about that, where those leads are positioned, that's looking at the top part of the heart. So it's looking at the electrical difference between these two leads. And it creates a picture of that difference. And that tells us what's going on with the top part of the heart. Lead 2 is looking at RA and LL, and it slices through the heart. So when we're first looking at telemetry, you always want to look at it in lead 2. It will make it easier for you to be able to figure out what it's supposed to look like, because when we start looking at all these other leads, it can look different, and that may be normal within that lead. But until you get your legs under you with being able to interpret EKG strips, you really need to look at lead 2. Lead 3. Lead 3 looks at the electrical difference between the left arm and the left leg. And so that is looking at the lateral part of the heart. So really that's kind of looking at the opposite area of lead 2, and also an opposite area of lead 1 as well. So that's 3 of our leads. All 1, 2, and 3 look at the electrical difference between two leads. Now we have 3 more leads that stem from the limb leads, and that's our augmented voltage leads. So how I want you to think of these is your augmented voltage leads is we are taking a picture of the heart. If it's coming from the RA, then that is our AVR lead. We're taking a picture of the heart from that one view. AVL is we're taking a picture of the heart from the left arm lead. And AVF, the way I remember it, AVF is foot. So AVF is going to be the left leg, because remember the right leg electrode is always our system ground, and it's not involved in this, but it's responsible for keeping the whole system together. RVF is going to be taking a picture upwards, looking at the bottom part of the heart. And we use the information from these different leads to be able to figure out where a heart attack is happening. And that's really more advanced stuff that we're just going to gloss over. I'll show you how it's done, but for the purposes of our class, we want you to be able to recognize the basic rhythms more importantly than being able to come up with some specific details. The pericardial leads. The pericardial leads are going to be the ones that are on the chest. And the V1, anything that has a V, V1 through V6 is all pericardial leads. These are all on the ribs. V1 and V2 are on the left and right side of the 4th intercostal space, and they're on the left and the right side of the sternum. So the next lead that you want to place is V4. V4 is at the 5th intercostal space, mid-clavicular line. So basically, immediately below the patient's nipple on that left side. Now, V3 is going to be placed diagonally in between V2 and V4. V6 is going to be placed fifth intercostal space, mid-axillary line, so directly below the patient's armpit. V5 goes in between V4 and V6, and it is again on the fifth intercostal space. This picture looks at cardiac anatomy. And so with this, the normal electrical impulse in the heart starts at the SA node. The SA node is in the upper right atrium, and it is connected through internodal tracts to the AV node. The SA node likes to beat at between 60 beats a minute and 100 beats a minute. Now, if I'm carrying groceries in from the car and I'm having to go up 2 flights of steps with those, the heart is going to respond by increasing my heart rate, and the SA node can actually increase that heart rate up to 150 beats a minute. Over 150 beats a minute, it's not coming from the SA node. It's coming from another source within the atria. So 100 to 150 is sinus tach. Over 150 we'll be calling supraventricular tachycardias. But our normal impulse starts at the SA node, and it travels down through internodal tracts. These internodal tracts, I want you to think of them like interstates. So we have a few interstates that connect different places in town, and we can drive faster on those interstates than we can going the back roads to different places. So, just like on the interstate, if a wreck happens, if something bad happens, then we got big problems. Same thing within the heart. If we have something wrong with the internodal tracts, we still can get there, but it's going to take us a longer period of time. So these internodal tracts are actually modified muscular tissue that is very similar to neural tissue. And just like the neural impulses in the body can conduct faster through jumping electrically at the nodes of Ranvier, the internodal tracts can allow the heart electricity to jump quickly to go from the SA node to the AV node. Now, the heart also has several fail-safes. So the normal heartbeat is going to go from the SA node, internodal tracts to the AV node, from the AV node into the bundle of His, and from the bundle of His it breaks down into the left and right bundle branches, carrying these electrical impulses to the ventricles, and it terminates in Purkinje fibers. So we have several fail-safes. You'll notice on this picture we have different rates listed. So if the SA node doesn't work, it likes to beat at 60 to 100. If it just doesn't work, then the next fail-safe is the AV junction. The AV junction likes to beat at, this is the AV atrioventricular bundle of His junction. It likes to beat at 40 to 60 beats a minute. So if the SA doesn't work, the AV junction says, hey, we got to take care of this. The SA is not working. So it creates an electrical stimulus and beats at 40 to 60 beats a minute. And with this, the complexes are going to look different because they're not coming from the SA node, they're coming from the AV node, the AV junction. As we go further down in the ventricles, if the rate is under 40 and is wide, anything coming from the ventricles is going to have a wide QRS greater than 0.12. Our normal QRS is 0.04 to 0.12. If our QRS is wide, then it's coming from the ventricles, okay? And that's going to be under 40. So in looking at our EKG complex, the P wave is when the SA node fires. It depolarizes in fancy medical terms. So atrial depolarization occurs with the P wave. And then after it fires, think about a gun. You have to cock a gun to get it to fire. So once it fires, you're going to have to cock it again and get it ready to fire. The getting it ready to fire happens during the QRS, and that is also ventricular depolarization. That's when the ventricles are firing, and electrically, what that means is that the ventricles are squeezing the blood out of the heart. So that is systole of the heart. And then from there, the heart gets ready to fire again. When the ventricles get ready to fire again, that's the T wave. So the T wave is ventricular repolarization. Ventricular depolarization is the QRS. Okay. And the atrial depolarization is the P wave. And it gets ready to fire again in the QRS. Why don't we see a wave for atrial repolarization? We can't actually see atrial repolarization because the QRS is coming from the ventricles, and the ventricles are so much bigger in size than the atria that it is buried within the QRS complex. So we also can have U waves. We'll see U waves. These are going to be zebras. You only see them a few times. But U waves we'll see in time periods when there's problems with potassium. And each of these intervals has a set amount of time that should be happening. So the way we count these boxes is when we look at these grids that we will have 5 little boxes within each bold grid mark. And so we are looking at it left to right, so we're measuring it in time, okay? The height is the electrical amplitude. So bold grid line to bold grid line is 5 little boxes, and that's 0.20. Each individual little box is 0.04. So we start counting the PR interval from the beginning of the P wave, that's when the SA node starts to fire, to the end of the straight line for baseline before it dips down to make the QRS. Okay, that's your PR interval or PR segment. Then the QRS is from when it leaves the baseline to make the Q wave and all the way through the R, the S, and when it hits the baseline again, that's our QRS. It should be 0.04 to 0.12. So our QT interval is going to be the amount of time from the beginning of the Q wave to the end of the T. And this is the whole time that the ventricles are involved in doing anything with a cardiac cycle. Okay, so you're going to need to know the normal intervals because we have to build on these. And you're going to need to know what is happening during each part of the QRS. Okay, so here's a review. With the P wave, this is atrial depolarization. Now, this is actually the British spelling for depolarization. and it was on this graphic. So here in America, instead of the S within depolarization, we have a Z in depolarization. The PR interval is the time that the impulse travels from the SA node through the internodal pathways to the ventricles. The QRS is when the ventricles depolarize and the atria repolarizes, gets ready to fire again. So the ST segment we look at to see if there's a heart attack, and this is where it should be at the baseline. If there's elevation, that's how we know there's a heart attack. Then the T wave is usually pointing in the same direction as the QRS. In lead 2, your QRS will always be upright, your P wave will always be upright coming from the SA node, and your T wave will always be upright. So if telemetry calls you and is saying, hey, you have some leads reversed, how they know that is because in lead 2, the QRS is negatively deflected, your P wave is negatively deflected, and your T wave is negatively deflected. So that's how they can tell if the leads are appropriate. And that's why it's easiest for you to look at lead 2 for any kind of EKG interpretation until you get your EKG legs under you. Once you figure out what you're doing with it, then you can start looking at what's going on in other leads. So, on an EKG, we have 12 different views that are made by 10 different leads. So, as we talked about earlier, different leads are going to look at different parts of the heart, just like I can take a picture of different parts of my car and see different things. So the blue leads, 2, 3, and AVF, are the inferior leads. They are looking at what is going on at the bottom part of the heart. The lateral leads are going to be the ones in red. Lead 1, AVL, and then V5 and V6. The anterior leads are orange. So specifically, looking at V3 and V4 are going to be specifically anterior leads. Frequently, though, we hear of anteroseptal MIs, and the septum is between the ventricles. So an anteroseptal MI is going to have ST elevation in V1 and 2 and V3 and V4 as well. So this is one of the more advanced skills. We're not really going to stress this for our purposes for the class, but this is how they can determine where the heart attack is actually happening, and they know which blood vessels to go look at to see where the occlusion is. So this is showing the paper. You assume that any strip that you're given in this class is a 6-second strip. One way you can tell the markings on the paper, when you look at the graph at the bottom, there are just spiked lines. Between each spike line is 3 seconds. So in general, when you are given a strip, it will be a 6-second strip. So remember we talked about on the other slide that the bold lines are 0.20. Between each individual little box is 0.04. And so 5 of the little boxes make a big box. And so when we're looking at it left to right, it's measuring time. When we're looking at it up and down, it's measuring voltage or electrical amplitude. So this is our previous picture of the heart earlier. And how do we know if it's coming from the top part of the heart or the bottom part of the heart? So if it's supraventricular, then it is coming from the atria, and you will have a narrow QRS complex. If it's coming from the ventricles, then it's coming from the bottom part of the heart. Your rate is going to be slower, and your QRS complexes will be wide. They will be greater than 0.12. The normal QRS is 0.04 to 0.12. So first we have sinus rhythms. If we have a rhythm and we call it a sinus rhythm, that means it is originating from the SA node. Normal sinus rhythm. Again, assume any strip that you see is a 6-second strip. And so with a normal sinus rhythm, we have a rate between 60 and 100. It is very regular. Our PR interval should be 0.12, and instead of that 0, that should say 2. So that mistake, I missed that one. So it's 0.12, 3 little boxes, to 5 little boxes, 0.20, because remember each little box is 0.04. Our QRS interval should be 1 little box to 3 little boxes, 0.04 to 0.12. Our QT interval will be 0.32 to 0.40. And so this is what defines normal sinus rhythm. Now, usually EKG strips are measured with calipers. We're not going to get very much into the actual measurements of complexes in this class, but I want you to be able to recognize the rhythms by glancing and looking at them. So this is a normal sinus rhythm, and that is all the normal features of it. Sinus bradycardia will have all the same normal numbers. The only difference is the rate is under 60. So anything under 60 with normal P wave, normal QRS, normal T wave is going to be a sinus rhythm. Sinus tachycardia. This is when the rate is over 100. And I've told you that the SA node does not like to beat faster than 150. So we'll call it SVT if it's faster than 150. So this is a sinus tach. So what's the difference in our supraventricular arrhythmias and our ventricular arrhythmias? Okay, our supraventricular arrhythmias are going to have a narrow QRS. They're going to have a QRS interval of less than 3 boxes. Whereas our ventricular arrhythmias are going to have a fat QRS. They're going to be wider than 0.12, more than 3 boxes. Our supraventricular arrhythmias, we commonly think of, are going to be atrial fibrillation, atrial flutter, and supraventricular tachycardia. All of these will have normal, narrow QRSs. Coming from the ventricles, we can have PVCs that we'll be talking about. These are premature complexes. I'm sure you felt them before, staying up late, studying for a nursing exam, load up on the coffee, and then all of a sudden you feel your heart skipping a beat. Those are premature ventricular complexes. It's completely normal to have PVCs as long as you aren't having more than 6 PVCs per minute. Also, ventricular tachycardia is wide. It's going to be coming from the ventricles. And ventricular fibrillation. VTach and VFib are both lethal arrhythmias. However, you can have a pulse with VTach, but if you don't get your patient converted out of it soon, they will deteriorate and go into VTach that's pulseless. Okay, PVCs. This is what PVCs look like. A PVC is a widened complex, and they can come from the same place. This is what PVCs look like in the top strip that are coming from the same place. They look the same. The second strip, these are PVCs that are coming from different places because they look different. So you can have PVCs happen just randomly. You can have them happen together as two in the third complex, and that's called a couplet. Or you can have three beats together. So three PVCs together is called a salvo, S-A-L-V-O. A salvo, by definition, is three beats. If you have three PVCs together, that can be defined as a 3-beat run of VTAC. And then the fancy medical word for that is a salvo. So now we're looking at if the SA node doesn't work or isn't working appropriately, then what happens is the rhythm will originate from the ventricles. And when it originates from the ventricles, then okay, sorry guys, I misspoke. If the SA node does not pick up, then the next fail-safe down in the heart is the AV junction. And so the AV junction likes to beat at 40 to 60 beats a minute. Okay? And so that is going to be our junctional arrhythmias. So a junctional rhythm, we have three criteria, one of which has to be met for it to be called a junctional rhythm. The first one is a very, very short PR interval. The PR interval is less than 0.12. Or I have an absent P wave, no P wave. So it's just flat before the QRS. I also could have an inverted P wave, and this is where in lead 2 that the P wave is negatively deflected. It's a hole in the ground instead of a lump of dirt above the ground. Okay, so this strip that we see on this slide has an inverted P wave. So that is a sign it is a junctional rhythm. Junctional rhythms like to be extremely regular, and they also have narrow QRSs because remember, it is coming from above the ventricles. When it's coming from the ventricles is when we get very wide QRSs. Here are other examples of a junctional rhythm. So with that, remember we have three criteria for it to be a junctional rhythm. No P wave, short PR interval less than 0.12, or inverted P wave. And so in both of these strips, we see no P wave before the complexes. And remember, we always want to look at interpreting in lead 2 before we really get good at interpreting. Once you get good at interpreting, you know what you're looking at in all the leads. So a junctional rhythm, the AV junction likes to beat at 40 to 60 beats a minute. If it's faster than that, it's called an accelerated junctional rhythm, and that's when the heart is increasing, trying to increase its cardiac output, and it will beat 60 to 100 times a minute. Now, one of the zebras that we see, you always assume that anything you see is normal or more common before you assume that it's a zebra. Junctional tachycardia is truly a zebra. I've only seen it twice within my career. So that is when you are originating from the AV junction and you're over 100 beats a minute. Atrial arrhythmias. first one that we're going to look at is supraventricular tachycardia. And technically, sinus tach can be considered as a form of SVT. I think that they should be cleaved out and done separately because sinus tach is a normal variant. When we start getting into supraventricular tachycardias, we're getting into stuff that isn't always normal. So with an SVT, that's the reason it says rate over 100. 100 to 150 is typically going to be sinus tach originating from the SA node. Over 150, that's really when you should start calling it a supraventricular tachycardia. You will have a narrow complex QRS and then a normal T wave. Sometimes you can't see a P wave, and the P wave is there, but it's buried because the rhythm is so fast that you don't actually have the time to be able to see the rhythm on the strip. Atrial fibrillation. This is going to be a common one that you see. When somebody goes into atrial fibrillation, it is a bunch of different cells within the atria that are getting excited and they're wanting to fire. So your baseline looks terrible. Your baseline is going to be very coarse and have bunches of jagged edges on the baseline. And it's going to be irregularly irregular. Okay? And that's because the atria is trying to beat so fast. The atrial rate can be between 350 times a minute and 650 times a minute. That basically is like a bag of worms. So you are losing atrial kick, that's where the top part of the heart squeezes, before the bottom part does, to help keep the cardiac output up. Your QRS complexes are normal, okay? But the big thing is it's irregularly irregular. When somebody is in atrial fibrillation, they need to be anticoagulated because if they are not on warfarin or Plavix or Eliquis or something like that to stop clotting from happening, they're going to blood that just kind of sits together clots, and that's what is happening in the atria because it can't have organized activity that fast. So both of these rhythms are an example of atrial fibrillation. The top one has a more coarse baseline. That means that the atrial rate is much higher, and that's what makes it so jagged. The bottom really has a smooth baseline, but it's irregularly irregular. There is no pattern that you can discern from looking at the strip. Atrial flutter. Atrial flutter. We have a sawtoothed picket fence type baseline. Okay. With that, these really aren't called P waves. They're called F waves because these are flutter waves. So with this, atrial flutter can be super fast, and we may have to slow the rhythm down by giving them adenosine to slow the rhythm down, stop conduction through the AV node, so we can actually see what type of rhythm it is that we're dealing with. So atrial flutter, atrial fib, both can be like that. But our QRS will be normal in atrial flutter. AV blocks. So this is when something is happening at the level of the AV junction, the bundle of His, that's causing a slowdown. So a first degree AV block is a normal variant, and this is when our PR interval is greater than 0.2. So look at the PR interval on this strip. It's the PR interval is in red. That is much faster than, or much longer than 0.20. So there is a slowdown within the AV junction, and it's just taking longer to get through. So for whatever reason, the conduction has slowed down as it's going through the AV junction, and our PR interval reflects that. It gets much longer. This is a normal variant. There's really no treatment, and your patient really doesn't have any signs or symptoms from this. A second degree type 1 AV block. This is also known as Winky Bach. So with Winky Bach, second degree type 1, we have the very beginning of the strip, we have a short PR interval, and then on that next complex, the second complex, our PR interval gets longer. And on that third complex, our PR interval gets longer. And then our fourth, we have a P wave, but we don't have a QRS. Okay? So this is called Winky Bach. The way to remember it is we short, longer, longer drop. That's the footprints of Winky Bach. So our PR interval is short. It keeps getting progressively longer until a beat is dropped. So short, longer, longer drop. That's the footprints of Winky Bach. Patients with Winky Bach or in second degree type 1, they generally don't have any signs or symptoms of this. But as we progress from second degree type 1 to second degree type 2, they tend to start developing more symptoms, and it becomes more severe because they're getting closer to third degree AV block, which is where the atria and the ventricles, they don't talk to each other at all. Second degree type 2. So with this second degree type 2, we have the arrows pointing at the P wave. Okay, so with this, our PR interval is constant. It's the same on all the beats that have a QRS, but we're just randomly dropping QRSs. Okay, so if we drop the QRS, that means the blood is not getting pumped from the ventricles to the body. So we're going to start seeing more significant issues from this because it's a higher grade block that we're experiencing. And so finally, our last type is called a third degree block. This is a complete heart block. And what happens with this is the P waves, the atria, is doing its own thing.